Now, just some definitions again to make sure that we are all in the same universe. It's an uncertainty for good or bad. Facing a risk simply means a choice has to be made. And risk communications is just all about explaining uncertainties to create confidence. Again, most of the self-evident points, I'll just go through this very quickly. It's a process of communicating honestly, manage well, it builds respect, nurture trust and confidence. It's not just about educating the public about risks, but also responding in tandem with public risk perceptions to help shape human behavior. Some basics, again, most of these points have already been raised. 3 key parameters that will convince people to take precautions. They need to be aware, they need to be informed. They need to believe that effective protective actions are available, and the risk needs to be carefully managed. Now I'm going to touch on SARS. Again, you have to see it in the Singapore context. In 44 years of our independence, we have not really encountered a serious epidemic. We have had minor epidemics, the Nipah virus from pigs, we've had foot and mouth disease, but we have had no substantive experience with pandemics or epidemics until SARS came along. So SARS was in many ways a defining moment. And what we went through SARS had implications for the kind of planning we put into place after SARS. And some of the simple lessons we learned: decisive leadership and involvement, transparency and honest communication. I have very great difficulty with the word transparency. I don't know of any government that is transparent. Unless you do, please tell me. Earning trust and confidence. I think the word is honest communication, really. Earning trust and confidence of the population, and employing a multidisciplinary, multi-sectorial approach with no artificial boundaries between medicine, engineering, and other disciplines. So for a small city like Singapore, when we had SARS, we brought in the Ministry of Defense, for instance. The thermal scanners were actually an innovation of the Ministry of Defense, Republic of Singapore Air Force. And the thermal scanners were used very widely first in Singapore for SARS. Whilst many countries now have pandemic preparedness plans in place, I think especially I'm talking of Southeast Asia, after SARS and avian flu, I don't see any universally accepted or organized method to evaluate preparedness. So I'll just touch on Singapore's particular experience. The objectives of Singapore's plan simply to reduce morbidity and mortality by delaying the entry and spread of influenza and giving the appropriate treatment of cases. Also, at the same time, to maintain essential services to limit social and economic disruptions. So after SARS, we put in place something called a disease outbreak response system. We call it in short DORSCON. It allows us to respond immediately to outbreaks and to ramp up measures accordingly. It comprises community measures, measures in healthcare settings, and border health controls. And what we do is we exercise this regularly. We have standard operating procedures for all the key ministries, key agencies, key organizations, and these are exercised about 2 to 3 times a year. The system, very simply, uses colors. Nothing novel about it, it's been done before. From green, which is no circulating novel influenza subtype, and then it goes into alert yellow, inefficient human-to-human transmission of influenza outside Singapore. Then in the next phase, of course, is orange, human-to-human transmission becomes more efficient. Alert red, which is a pandemic is underway, has spread to Singapore. Significant risk of acquiring disease from the community. And finally, of course, the doomsday scenario with the black, where morbidity and mortality rates are very high, and emergency measures are needed to bring the situation under control. I just want to show the difference, or rather the slight distinction between the WHO classification in the Singapore system. The current WHO phases 1 to 6 describes the spread of the disease across the world, but it does not take into account disease severity. Now, Singapore's DORSCON framework is based on the character of the virus, its transmissibility, how easily it spreads, and its virulence, the severity of illness caused by the virus. So, the simple point is that our DORSCON levels need not change in tandem with WHO's phases. But that's easier said than done, because when the media reported WHO's alert levels rising without the Singapore levels rising concurrently, we had the public asking us, are you people sleeping? Are you doing anything about it? Why are you not panicking? So, the communication became a little tricky, because it's all very well to come up with all these technical distinctions, but the proverbial man on the street doesn't have a clue what you're talking about. Singapore's response, a very early activation of something we set up in substantive terms, our Homefront Crisis Executive Group. It is chaired by the Ministry of Home Affairs with the Minister for Health as the lead agency, just 2 days after the first press release on the Mexican outbreak on 25th April. Now, this structure essentially allows for sharing and coordination of resources across all government agencies. We put into effect a containment strategy, border controls, contact tracing, quarantine, stockpiling masks and antiviral drugs to prevent local transmission. What did it do? I know all the criticisms of containment, we've seen the criticisms in the literature, but it brought us time. It gave us about 7 weeks to prepare the public psychologically, to gear up the system we had in place for community spread. So we were able to use the 7 weeks for substantive ramping up of hospital facilities, public hospitals, polyclinics to treat walk-in patients, laboratory facilities and testing. And the community spread in Singapore was evident only in the later half of June 2009. Just to give you an idea of how the system works, the crisis management group in this instance happens to be the Ministry of Health. If it's a tsunami or an earthquake, it would be the Ministry of Environment and so on and so on. And then there are crisis management groups. And the moment this group is mobilized, it was mobilized within 3 days after, all our resources are concentrated to make sure that we solve this problem. So there's a complete sharing of resources across ministries. We found that this was lacking before SARS, simply because we didn't really conceive of a crisis which would actually transcend across ministries. You're always confident your Ministry of Home Affairs will handle Homeland Security, your Ministry of Defense will handle external defense. It doesn't always work. On May 26, Singapore had its first confirmed H1N1 case. Again, that created problems because it came from a young student from Singapore Management University who was in Mexico on attachment. And when she returned, she brought in H1N1. Unfortunately, the bloggers went wild. They abused her in the blogs about bringing the disease and so on and so on. There were 3 waves of exported cases from the United States, followed by Australia, which was a bigger wave, and then from the ASEAN countries, including Philippines and Thailand. By mid-July, Singapore was on the last leg of its fight against the disease, with focus on mitigation efforts, devoting resources to manage high-risk patients.